So I would like to invite the next panel up to the stage, if we could, please. We have 4 individuals who are coming up to the stage. We have Dr. Val Waters. Val is an associate professor of pediatrics at the University of Toronto, an infectious diseases consultant for cystic fibrosis, the clinic at the Hospital for Sick Children. Val, do you want to sit here? And then Liz, you want to be here? And then Brenda over here? Yeah, and Chris, you're here. She is also a consultant at the Hospital for Sick Children in Toronto and a senior associate scientist with the Research Institute at the Hospital for Sick Children. She studies multi-drug resistance, biofilms, the clinical impact of pulmonary exacerbations, and the pulmonary microbiome in cystic fibrosis. Dr. Tullis, to my left, is the director of the Toronto Adult Cystic Fibrosis Clinic at St. Michael's Hospital and is responsible for the care of more than 500 adults with cystic fibrosis, more than any other clinic in Canada and one of the biggest, if not the biggest, in North America, I believe. She is a professor of medicine at University of Toronto, respirology division head at St. Michael's Hospital, and an adjunct scientist at the Li Ka-shing Knowledge Institute. She is a multi-prize winner and held the Cystic Fibrosis Canada Chair in Adult Cystic Fibrosis Research from 2014 to 2019. On my far left is Brenda Chambers-Ivy. Brenda lives with cystic fibrosis, is a lung transplant recipient, and has worked in college administration for the past 15 years. Her involvement with Cystic Fibrosis Canada spans 45 years. She recently rejoined the Adult Cystic Fibrosis Advisory Committee, is a community stakeholder on our scientific review panel, and a regional advocate for Ontario. And Brenda remembers the summer camps. Chris Quam was diagnosed with cystic fibrosis in 1984 at the age of 4. He is currently a spouse, a father, an assistant district attorney, which always impresses me, a published author, and an athlete. He ran competitively in college and continues to use exercise, to our earlier comment, to motivate his adherence to care. I know Chris through his participation, kind of on a couple of bounces, 2 degrees of separation, his participation in Gear Up for CF, a 900-mile ride across the Canadian Rockies for Cystic Fibrosis Canada. So some of you know that I'm a biker, and when I say ride, this is a bicycle ride. I would not be able to do it, and so I'm very impressed by that event. He spoke at the 2014 North American Cystic Fibrosis Symposium on the recommendations of the Mental Health Guidelines Committee, and he continues to serve on the CFF Mental Health Committee. He is also a champion of the patient as expert in their own care. So, I want to thank everyone for still being here and for sticking around for this important conversation. I actually planned this to be the last one in the hopes that we would be able to retain an audience, because sometimes we lose people at the end. I also want to say that I've been looking forward to it with great excitement, but also great trepidation. The discussion the topic of infection prevention and control and Cystic Fibrosis Canada's policy on infection prevention that derives from it, those guidelines, can be a contentious one. It seems capable of eliciting some rather strong emotional responses and no small level of controversy, to the point that there was some contention as to whether simply having the conversation was a wise choice. You will note that there are, in fact, 2 people living with cystic fibrosis on stage here today, a clear breach of Cystic Fibrosis Canada's policy and an aberration that is on me. I will confess to some level of discomfort for 2 reasons, and one of them being that the notion that I, or personally, or Cystic Fibrosis Canada, would ever do anything that would actually harm an individual with cystic fibrosis is anathemic. We're not questioning the policy, but we need to also acknowledge that that policy, when I joined the organization 4 years ago, it's something that comes up over and over and over again, and we need to acknowledge that the policy and the guidelines have had a significant impact on people who live with cystic fibrosis. And that at a conference where the theme is patient engagement, it was felt important to be able to at least have the conversation and hear the voices of people living with cystic fibrosis. I want to start by asking Dr. Waters and Dr. Tullis about the background behind the guidelines. I acknowledge the tremendous time and effort that went into developing those guidelines back in 2013, and I'd like to get a little bit of background about the rationale for looking at them. There was an initial one in 2003, and then we looked again at them in 2013. I was wondering if you give us a little bit of history. Who was on that panel? Who developed the guidelines? If you give us some more of a history on that.
So I think it's helpful to maybe start the conversation a little bit earlier, because there were infection.
Mike?
No, I don't. I'm wearing it. I'm good. Can you hear me? Yeah. Okay. So I think it's helpful to start the conversation a bit earlier, because CF Canada, when it was the Canadian Cystic Fibrosis Foundation, did have infection prevention and control guidelines, even when I started, and obviously before that. But that was around 1990, and there's lots of faces in the room of people who were my colleagues at that time, and they'll remember them. And a lot of this came around the time of the summer camps and the understanding in the late 1980s and the early 1990s that there was person-to-person spread of bacteria. Toronto was kind of a bit of ground zero for this, because the spread of Burkholderia cepacia complex led to the death of a number of patients, and it was shown that this was person-to-person transmission. And that had a huge impact on the lives of people with CF that we have all looked after. And so the initial guidelines from the Canadian CF Foundation were that people with CF who had B cepacia complex should not attend events and should not be in contact with other people with CF. So the people with B cepacia complex were marked out as those people that were the highest risk. And the initial change to the camps was no people with B cepacia complex could attend. But it became very clear that you don't know what bacteria people grow in your lungs until 7 days after you've done the culture. So within a short period of time, that changed to no summer camps. And so that people with CF lost that opportunity to interact with other people with CF. And many of my patients, like Brenda, attended those camps and speak of it very fondly, of that opportunity to connect with people who really understood what it was like. And so that was a big loss for the community. But it came from a place where the study showed that if you went to camp, 10% or 11% of the people who went to camp came home with B cepacia complex, and none of the children followed in the regular clinic over the summer months got B cepacia complex. And so the risk was there. And so then in 2005, the policy morphed to include MRSA when it was recognized that MRSA also had a bad outcome on patients. And then I was the chair of the clinic subcommittee of Cystic Fibrosis Canada at the time when Sean Aaron's study was done looking at adults with CF in Ontario and showing that 15% of them actually carried the Liverpool epidemic strain of Pseudomonas. And this was not, I think the only clinic that was not involved was Kingston, which is a relatively small clinic. But every other adult clinic in Ontario had patients with this bacteria. And the thought is that perhaps that was due to the contact in the camps, because children from the UK attended the camps in Northern Ontario. So we had evidence that Pseudomonas could be spread. And so it was in 2011, way before the guidelines that the Americans put in place, that CF Canada said we won't have two people with CF together because there is a risk of transmission regardless of the type of bacteria. And there's no bad bacteria and good bacteria. What you grow, if your body is managing it, is fine. But that might not mean that somebody else acquiring it would have the same good outcome. And I have people with CF that I look after who have grown B cepacia complex, the Toronto strain, since 1986, and they're doing well, and they don't get admitted to hospital, and some of them have 85% lung function, and they're in their 50s. But I do know, over the almost 30 years that I've been a CF doctor, of many people who have passed away because they have acquired this bacteria, often within weeks or months of acquiring it. So there is a risk, and CF Canada was in fact ahead of the Americans. And so the guidelines in 2013, which the process started in 2011, was 21 people, I believe. I was one of the participants, the lone Canadian participant, but there was 4 infectious disease doctors with the same background similar to Dr. Waters, 4 respirologists, 3 parents of children with CF, 1 adult with CF, and then nurse, respiratory therapist, and members of the American CF Foundation. And the guidelines was convened to look at the new evidence of transmission of infection and to see if there needs to be updates made because of the increased understanding in how bacteria are transmitted from person to person. And that's a better question for Val to answer than me, as she's more an expert in that area. But looking at all this information, that's where these new guidelines came from. With the great recognition that, like the closure of the camps, that preventing people with CF from being together was a bad thing from an emotional point of view and a support point of view, and that was an unfortunate kind of consequence of what was happening. And so lots of push for better ways of using new technology to link people with CF in a way that was safe. And the recognition that the infection control guidelines are really all about risk and risk reduction. There's never a place that you're going to get where there's no risk, and that it's impossible sometimes to quantify risk. Some illnesses you can, some situations you can, but infection prevention and control is a little bit more difficult to put numbers on. So that's kind of where the history of things, and I was very proud to actually be a Canadian in that room, because a lot of the things they were talking about, I said, well, that CF Canada already, that's their guidelines already. So we were really thinking sort of ahead of the time.
You were ahead of the curve at the time.
Yeah.
And Val, would you like to speak to us a little bit about how patients acquire infections and how you might find patient-to-patient infections?
Sure. So I think Liz laid out really nicely the history of what's happened with the infection control guidelines. So we focus a lot on the gram-negative pathogens, Pseudomonas, Burkholderia, Chromobacter, and those are organisms that are environmental opportunistic pathogens, which means they live in soil, in water. They're often intrinsically multi-drug resistant. Patients generally initially acquire these from the environment, either from soil or water exposure. We never really know exactly where. And that they acquire individual strains from the environment. But there is well-documented patient-to-patient transmission that can occur of these organisms as well. And there's a number of ways that patients can transmit. They can transmit by contact, which means if my hands, for example, are dirty and then I touch you, I've transmitted an organism by touch. You can transmit by droplet, which means that particles that you cough up travel up to a meter and then are touched or inhaled by another patient, and you can transmit that way. And on the rare occasion, CF patients can transmit via an aerosolized route, which means that droplet particle size go beyond a meter, which is what we classify as airborne. So the precautions that we use of the gown and gloves is what we call contact precaution to prevent the contact transmission. The masks are for droplet transmission, and rarely we would use N95s for airborne transmission. So the guidelines that we use from the IPAC for CF with the gowns and the gloves is designed to minimize both the contact and the droplet transmission that can occur. And when there have been several studies that have looked to see the effectiveness of these guideline recommendations. So Scott Bell's done quite a bit of work where they've looked to see how far Pseudomonas can be transmitted, and they have shown that adult patients with chronic infection can transmit Pseudomonas up to 12 feet or 4 meters, and that the particles can remain viable for 45 minutes within an environment, within an air. So when they've looked at masks that patients wear, they've shown that they've been able to significantly reduce the viability of the Pseudomonas that can be transmitted from a coughing patient. Similarly, one of the other guideline recommendations was to have at least 30 minutes between patients who are negative pressure for the pulmonary function testing that's done. And Dr. Seaman was able to show that with a 30-minute gap between patients, you can decrease, again, the amount of viable Pseudomonas that you can recover in a room after an adult with CF has gone through it. So the precautions we used are designed to try to minimize that transmission. As Liz says, nothing is ever a zero risk, but it's been designed to try to minimize that risk, and there's been some studies to show that it's efficacious in terms of reducing the amount of burden of organisms that you can recover in the environment.
Okay. And Liz, the guidelines, I think they have something like 78 recommendations. Of those recommendations, how would you categorize the vast majority of them? Do they apply to healthcare settings? Do they apply to non-healthcare settings? Just give us a bit of a breakdown on where they apply for the most part.
So it's a very long document. It's a good read. I wouldn't say it's a riveting read. But most of the guidelines are really based on the healthcare setting. You know, that the challenge in CF is that we know that the CF clinic multidisciplinary team, regular clinic visits is associated with better outcomes as opposed to just going to see your doctor or going when you're sick. But bringing a whole bunch of people together with CF doesn't make a good sense in terms of transmission.
Risky.
Exactly. So the guidelines are really focused mainly on the healthcare setting of either the clinic or the outpatient in order to try and make that environment a safer environment for the people with CF who are coming to get the benefit of the clinic. And a lot of the guidelines are more talking about, you know, how equipment is cleaned and how, you know, nebulizers, for example, are cleaned and how should PFTs be done. But it's all mostly within the healthcare setting with some comments about home environment and outside environments like swimming pools and hot tubs in schools, and what to do if a person with CF actually works in the healthcare setting, is a health professional themselves. So it's a bit of extrapolation, and the extrapolation actually came because of the questions that the CF community made to the CF Foundation saying there needs to be some guidelines about these other things.
Okay. Chris, Brenda, let me ask you, would you concur, where do you feel most unsafe?
I think without question I feel most unsafe in clinic or in hospital. And differentiating between a CF clinic as an outpatient versus being hospitalized as an inpatient.
Okay. And would you concur, Brenda?
I would say the same thing, and I've talked to, anticipating coming here, I've talked to a number of CF adults as well, and I hear the same thing over and over from other CF adults as well.
So would it be fair to say that certainly the recommendations and the guidelines, certainly as they apply to the healthcare setting in terms of reducing risk, are something that you are in favor of?
I think they are worth acknowledging. I think it is equally important to acknowledge that I still shoulder an amount of risk when I come to clinic, and that is something that I choose to do.
Okay.
Same thing. It's a calculated, I mean, every time we walk outside our door, it's a calculated risk in some way, shape, or fashion. But we know that going into clinic and we know going into these settings that we can be exposed to things, but we also know that you do take precautions to protect us.
And as we learned, some of the recommendations, some of the guidelines actually apply to the non-healthcare settings. Can you talk a little bit about the impact that might have on people living with cystic fibrosis if those guidelines are strictly applied?
I think that if taken to their extreme, they result in an extremely fear-based existence. And there's very little difference between someone being told to live in a bubble and someone told to follow the infection control guideline to the letter. And I think that has a hugely negative impact, and I don't think that it's in line with what the risks of cross-infection or environmental infection actually are. And I know they're hard to quantify and that we haven't done so, but I also know how a lot of people with CF have lived their lives, not just myself. And I know that I am a far fuller and happier person for accepting some of those risks and not running my life by them. I'm also cleaner because I shower. That's a joke.
Brenda, one of the things that when we talk about risk reward, people go to the clinic, they're exposed to a risk, but there is a real reward from going there. We can demonstrate that people do better when they get that multidisciplinary care.
Yes.
Perhaps what might be a little bit more difficult is for people who don't live with the disease to quantify or to understand what might be lost when people are told you can't physically get together. Mm-hmm. I think we're all familiar with the notion that there are peer support groups in other conditions. You've been around for a while. You remember the summer camps. Can you speak a little bit to perhaps help us understand, those of us who don't live with the disease, maybe the impact that might have, so we can help understand a little bit better that risk reward?
Sure. I've been involved with Cystic Fibrosis Canada. I guess you guys can hear me better now. I know I tend to talk quiet. For many, many years, I never did actually attend the camps, but I was lucky enough to live in an area that was like being at camp all the time. Being able to get together with a group of peers from across Canada to gather, to exchange ideas, to support each other, share knowledge, you can't measure that. There's definitely a reward in that. We didn't know the risks then. I mean, I understand that, and we do now. But there were so many takeaways, and I've talked again to other adults that were there at the time that were able to attend some of these meetings, and they said, even now knowing the risk, they do not regret anything as far as us coming together and the ideas and exchanges and what we were able to do for that adult community because of those exchanges. I mean, I'm very thankful now that we do know, we have the knowledge of these transmissions, et cetera, so that we can protect ourselves. And I think there's a way that we can be involved in that, probably through the Adult Cystic Fibrosis Advisory Committee, perhaps. We can take that policy and improve upon it. I think that would be a great goal to make everyone happy, I'm hoping.
Val, people get exposed to pathogens just in the natural environment. You can get them at home. I understand there's some risk of humid showers, for example. I wonder if is there a difference between the infectious agents that might be harbored by a patient to what someone might see in the environment?
Yeah, I mean, I guess, to clarify, patients who do not have CF are not exposed within the environment to organisms that are considered pathogens to them, right? So we're talking within the CF population. Are the organisms is Pseudomonas from the soil different than Pseudomonas from another patient? Well, it could be. The Pseudomonas from the environmental sources, for example, tend to be more drug susceptible, tend to be more able to have lower increased ability to be killed by tobramycin, for example, whereas one that is in a patient may be more multi-drug resistant just by the fact that a patient has received multiple courses of antibiotics. So there may be a selection pressure in that pathogen we know has existed, has established lung infection in that patient, and may be causing them harm, that you may be selecting out for more virulent Pseudomonas. That being said, as Liz, very nicely said, a particular organism may cause issues in one patient, not necessarily in another. So it's hard to generalize across all patients, but we do see differences in Pseudomonas from the environment than patient isolates, and predominantly with respect to antimicrobial resistance. I'm not sure if that's exactly what your question was. But.
No, it exactly is, because in terms of looking at always that risk reward, if you're comparing risk of people getting together versus risks of just being out in the environment, if there is an accrued risk because
Right.
people carry more,
Okay,
the bugs
so
are more dangerous.
I see what you're saying. Yeah. So, and also, I think I would also say that the bioburden is probably more. So, if I take an adult CF patient who has chronic Pseudomonas infection, for example, they have a large number of organisms in their lung, like 10 to the 8th, 10 to the 9th, like colony-forming units. So, a lot of very concentrated organisms that have potentially seen a lot of antimicrobials. Whereas in the environment, and we get this question from parents of CF kids a lot, you know, if they go to the splash pad, if they go to the water park, if they go to the pond, or they go here, there, yes, there may be Pseudomonas, but it's likely at a much lower concentration, if I can use that word. And it is very difficult to quantify the risk of acquiring Pseudomonas, for example, you know, going to a splash pad or a water park somewhere. So the level of risk that parents are willing to accept, and I say parents because that's what I do pediatrics, but a CF individual would be willing to accept, I think, for environmental exposures varies quite a bit. So, because as Chris says, you know, you can't live in a bubble, and I do explain this to parents, and even avoiding all those environmental activities, you could still get Pseudomonas, right? And we do see that sometimes too. So I do think that there is more of an inherent risk of a Pseudomonas coming from another patient than there is if it came from an environmental source.
Chris, you participated on the mental health guidelines, and you participate on. Do you have any insight from those guidelines? I mean, does the isolation that people might be feeling, has that had an impact that is documented or is understood?
I don't know how much it's been documented, other than certainly living with CF can be very isolating. A lot of my experience and thoughts about infection control come from working on that committee and being given or denied opportunities to share that work with providers and clinics at NACFC or in settings like this, where obviously I'm a desired voice and we would bring you but, or we would include you but. And to me, I have problems with the idea that, okay, in that setting, how large is that risk compared to clinic? Because I think it's easy to argue that it's less. In that setting, is there a value to patient voice that you should want to amplify? And should you not put it on adults who you are affording opportunities to make those decisions? I also think that, yes, the increases in virtual technology have been great. It is not the same as attending in person. I've had 20 conversations with people in this room in between sessions about important stuff that this community is working on that do not happen when you hit hang up and Ronnie goes away. And I think that's worth acknowledging. I don't see attending at NACFC, which I've done as the designated person. When there as the designated person, I'm not the only one there with CF. It's like the worst kept secret in the world. There's at least 10 other people there. They may not be presenting. They may not be invitees, but they are there. So I'm not actually being protected. So I'm still having to make the exact same risk assessment about attendance, as if I was saying, well, you've been invited to speak with Brenda, and you and Brenda can email each other about what you're culturing and what your comfort levels are, and if you're actively sick or coughing or not, and make a choice like adults. And those are completely separate questions than, because you have CF, we're not going to have you attend because you're going to be in a 5-acre complex where someone else in that building is going to be in a different room and they have CF too. That to me is not based on science, and it ignores the very real risks I live with every day, because I don't live in a vacuum where I only encounter people with CF as I walk into clinic. Because everyone in my hometown shops at Wegmans, which is the best grocery store ever for all of you that don't know. Everyone, I was in law school. I registered outside of my law curriculum with the School of Social Work to take a social work class about health law. 2 months into that class, we figured out that another person in that class had CF. I'm not going to drop the class. I've already been exposed. we're going to have a conversation about what we're growing, and if like, okay, do we really have to get serious, and am I going to start wearing masks in class and whatnot? And that's a conversation I can have with another adult. I've walked onto airplanes and seen people I know from social media on the plane flying to a different connecting city. That happens, and that's real, and I accept some of that, and sometimes I'm like, wow, I need to turn around and I need to make a different flight plan, or I'm like, good thing I packed my mask. Good thing I'm not, totally going to freak out right now. And that's life. I think that's life with CF. I don't think that social media is a solve necessarily, because if you're 15 years old and you have 500 friends on Facebook or Instagram or whatever with CF, you're going to see some stuff that's going to drive anxieties and depression in a way that just living as a person doesn't. So I don't think we get to just say, oh, well, social media exists now, you're fine. I think that's lazy.
Brenda, do you have any examples? Do you have any examples from members of our community, families, where the infection prevention and control policy has maybe had an impact on them?
Sure. I reached out to, again, anticipating coming here, I reached out to people. Just the approach I took was there's no right or wrong answer here. I'm just looking to see how you feel about this. Because, I mean, I have a group that I am in contact with, but there's many CF adults out there that I don't get a chance to talk to all the time. So I've just got snippets here. I'm not going to read whole things to you, but people agree with the policy being in a hospital setting. But outside of the hospital settings, the CFC doesn't own your person. And these are other people's quotes, by the way. This is not coming out from me. I think education and awareness is key, that patients understand all the information around infection issues so they, in capital letters, can make whatever decision feels right for them, not have someone else do it for them. This other person says, I'm careful, but on the other hand, I have no problem being around another CFer. But then she goes on to talk about what Chris had said, disclosure, having that informed conversation with another person. She says, think about when you're sitting on the subway or in line at the store, how do you know the person beside you doesn't have CF or another contagious disease? We don't know these, and that's where the risk reward, and every time we walk out our door, we take a risk. I agree with aspects of the control policy, but could use some fine tuning outside of the clinic hospital setting. So that's something I hear from a lot of people. People would like to see self-enforcement versus control. And one thing that brings up, and then the sense that I'm getting from people is it has divided the community in some sense, which was a totally unintended consequence. We know that, but it really has, there's people with some very strong opinions. I talked to one lady who, when this was first enforced, she actually shut down her chapter because of it. She was so upset that I said, okay, I can fundraise, I can do all these things for CF, but I can't attend. So that was her very strong emotional reaction to it, and she still feels very strongly about it. And I think one thing, another thing, some people thought it was fear-mongering. I mean, that's a strong word, I'm sorry. And other people thought, okay, well, we can't be united if we're divided. That was another strong theme that came across as well.
Liz, I want to come back to you because there's a question here of education. And could you talk a little bit about the impact, the positive impact that the infection prevention and control policy has had in reducing cross-infections in general?
Yes, I think that the education side is the education of healthcare professionals and the education of the broader CF community. So the infection prevention control guidelines have really helped in education of healthcare professionals because it's come up. I mean, it's controversial. There's a lot more is understood about transmission of bacteria. We've seen the positive effects of the changes in infection control policies in terms of reduction in the prevalence of B. cepacia complex in the United States and in Canada, as well as across the Atlantic, so that the changes that have been made have resulted in lower incidence and sadly, the lower prevalence is the death of people with these bacteria, but the incidence has gone down. And there have been some changes now with MRSA in the United States based on infection prevention and control. So we've actually seen that educating healthcare professionals to follow the guidelines, because there is controversy. Some centers do not believe in the guidelines. Some centers do not follow them. Some centers follow some of the guidelines, but not all of them. So
wouldn't that even that be important for certainly the people in the community to be aware of?
Yes, and I think that the next part is education of people with CF and their families. And it's complicated. Like, it's really hard in a short conversation in a clinic or in something on your website to communicate, you know, a quarter of Val's brain, you know? Like, there's a lot of knowledge of transmission. There's a lot of information, and it's hard to, you know, example might be cigarette smoking, you know, education of the public about the dangers of cigarette smoking. Like, that's, you know, that takes decades of public health policy to get the information out there. And so my concern is when I talk to people with CF, is that they don't have all the facts at their hands in order to make that risk decision. So I completely agree with individuals having to decide, you know, what risks they're going to be willing to take. So some people will do skydiving and other people won't. And some people will go and walk on that skywalk at the CN Tower, and people like me are like, I don't care if no one's died, I'm not doing that. And a lot of it comes from, I know on that skywalk, even though no one's died, if something happens to that harness, that 1 in a billion chance, you do not come out of that alive. And so risk, I think, is educating what the risk is to the best of our understanding, but it's also the consequences of the risk. And so if the consequence is you're harmed a bit and you spend a couple days in hospital, fine. If the consequence is you fall how many thousand feet and you're dead, then that's a different consequence. And as a CF doctor who worked in Toronto and who has unfortunately experienced the consequences of infection with Burkholderia ceanocepacia, and even the consequences of spread within the healthcare facility which I take as a personal responsibility, you know, people have died because of this. And some of my patients have died because of transmission by being in a car together and having transmission, so outside of the clinic setting. And I just feel like I'm not sure I can, as a community, we can quantify the risk enough and we can share the risk well enough with everybody to make the informed decisions. And I'm not always sure that people understand that the consequence may mean death. And so it's allowing people to make decisions. As a healthcare professional, I feel there's a responsibility that I have to make sure that they have all the right information. And I'm not sure that we can do that adequately.
And well, to that point, I mean, do we actually have that information? Are we able to quantify it? For example, Val, I mean, I'm thinking NTM. I mean, I don't know if we actually are able to measure patient-to-patient transmission outside of a healthcare setting. And I'm wondering, you know, would NTM, non-tuberculous mycoplasma, for those who are online, mycobacteria, is for you, is that a game changer? Is that something that's I guess, how would we call it, an emerging pathogen?
Oh, definitely.
Is that a bit of a change or two for you?
Definitely. I mean, Liz is talking a lot about cepacia, and we know cepacia very well, but you know, there's death that occurs with Pseudomonas. There's an outbreak of M. abscessus that occurred in a Seattle transplant center. 80% of patients died who were infected with that. MRSA, risk factor for death as well. So I think that, you know, it's cepacia, but it's the other organisms absolutely as well. And trying to quantify the risk, as Liz says, is difficult because transmission may occur with very obvious negative consequences like ceanocepacia, and a new isolate in a patient, very drug resistant, obviously ET12, and a patient will die of cepacia syndrome. But transmission may occur that goes undetected as well. Because to be able to tell if a patient has
an organism's been transmitted from one patient to another, you need to genotype that organism. You need to look at its DNA fingerprint, so to speak, and be able to distinguish that from environmental type isolates. And that's not something that we do or can do routinely in the clinical micro lab. So, being able to monitor for transmission and shared strains between patients is not an active clinical thing that we can do in the CF clinic. So we may not even have the full scope of how much is actually shared between patients. There are research studies that have looked at this, but outside the research setting, this is not, we don't do routine surveillance by genotyping in these isolates. So we don't know actually how much transmission may be occurring. And what we do know is tip of the iceberg type of thing. It's those where it's very devastating consequences with very drug-resistant organisms. So therefore it's difficult to quantify how much transmission potentially does occur and what is the risk of patients being together. And I agree with Liz that when you're assessing risk, you have to look at the consequence. And when the consequence is death, then it influences.
So I want to do a call out to our online audience, and as a reminder, you have about a 20-second delay. I'd like to invite the online audience. We don't really have a call-in line, but I would like to invite you, if you have a question, to please send that through. I believe there's a chat function or an email function that where you can send that, and we'll start collecting some questions from the online audience. I wanted to go back to you, Chris, you'd made a point earlier about education as empowering the patients, and I was wondering if you wanted to elaborate a little bit on that.
Sure. I mean, I'm a criminal prosecutor, right? Like, I am all about rules and enforcement and consequence, right? And ultimately, these guidelines are not enforced, right? You don't go out, there's no infection control police, okay? All you can do is educate and kind of hope for the best, while also controlling the spaces you can control in clinic to the best of your ability, minimizing substantial risks that you can identify. Now, and those go beyond patient to patient. Multiple studies have shown that 5% of all healthcare workers culture MRSA. There's about 100 of you here.
MRSA, right?
MRSA, yes, MRSA. There's about 100 of you here. Okay, like, what does that mean for me as a patient? What does that mean for clinic staff and clinic space? I don't know. I know that I'm willing to go to clinic. I think that ultimately your best chance at ensuring smart, non-reactive behavior in people is not to create a culture of rebellion, but to create a culture of intelligent decision-making based on an acknowledgement of the value of some level of contact when taken appropriately, because there's a scale here. There's a scale between spending 24 hours a day for 2 weeks in a summer camp and meeting outside at a cafe for coffee. Those are two different types of interactions. There's a difference between feeling like you have to glove and mask in order to walk outside your home and thinking that Will and Stella should have gone for it. Like, there's a scale. For any of you who have seen the movie, that's a joke. But, like, there's a difference. And I think in a disease where it is every day and it is every moment, we've all met teen adolescents with CF and without who enjoy rebellion. Don't make this the hill they literally want to die on. Because the risk doesn't always demand it, right? And there's a difference, again, between, summer camp contact, between housing, people undergoing treatments in hospitals in the same room. Like, yeah, clearly that was a bad idea, right? But now we know more and we don't do that. Does that also mean that as adults, people can't be encouraged to learn how to effectively form bonds of value that acknowledge risk and act accordingly?
We have a live audience here that covers a wide swath of individuals. Exceptionally, we have, this is typically Broken Arrow, is typically largely just scientists and healthcare professionals, clinic directors, but we also, this year, we have a number of parents in the audience as well. As we've heard that the clinical, the guidelines and the recommendations apply primarily to the healthcare environment, I would love to hear any comments from the audience as we continue. If anybody has any comments, there are microphones around the room. I'd love to hear it from anyone, from parents, from healthcare providers, researchers. I would like to hear if they have some comments, and we already have some here. Someone at the microphone there. Please identify yourself, because for our online audience, they won't see you and they'll just hear you.
Hi, I'm Ian Ferris. I'm Ontario Provincial Advocate, as well as a mother of a child with, I guess he's not a child anymore, he's 21, who lives with CF. And I guess I go back to the education piece, because there's also a fear that we're not educating outside of our CF communities. So my son may go to the hospital in Chatham, who is not familiar with CF. They sit him in a waiting room for 6 hours while he's amongst all kinds of other sick people. So it's about educating beyond our CF communities as well, educating our schools. He was in a classroom again with a child with CF. He was not aware that that child had CF. When I contacted the school and I talked to them about that, well, we have no way of identifying that. Yeah, you do. You have medical documentation that we have to fill out every single year that says he has CF, unless the other family is not willing to disclose that. But how do we protect our kids in those situations as well? And I agree with you, Chris. You know, he's probably going to take a risk anyways. He walks out to the door. He doesn't know if he's walking down the street with somebody with CF. And it does take away that bond and that human connectiveness. And we need that human connectiveness. Virtual connectiveness is not the same. It's difficult for him when he has anxiety and depression, when he can't reach out to somebody else that he knows that is going through similar situations. So I think we have to, yes, inform, but yes, not only inform our patients, but inform the broader community about the issues that we face. Because we as parents and we as people living with CF, we can go to the school and we can disclose that, but not necessarily do they take us seriously. Because, you know, they might just be overreacting. You know, it might be an overreaction to the fact that, you know, because he has a really bad cold and shouldn't be in school, they don't understand the ramifications that could have on our children.
There is, and we've heard that many times, this accrued sense of isolation because it is an invisible disease. And so people living with the disease, they don't necessarily look ill. Behind you, Hugh, please introduce yourself.
Yeah. Hugh Aucoin. I'm a member of the board of Cystic Fibrosis Canada and happen to be a pediatric pulmonologist. Really enjoyed this session. I guess our mutual goal is to avoid the boy or the girl in the bubble. And on the other hand, we want to avoid physicians who care for patients and forever blaming themselves when a patient dies of fulminant septicemia. So we'd like to avoid those two ends of the spectrum. Chris articulated very well being able to make an informed consent, and you will determine the risk assessment. And Liz mentioned about the outside of the sky door. I'd like to ask Chris and Brenda, what metrics would you use to satisfy yourself or the general community that sufficient knowledge had been given to the patient to be able to make their personal decision within their frame of reference? And the second question, in pediatrics, we talk a lot about consent and assent. When does the patient's priority, i.e., trump the parent and the rest of the family? So assent, consent. So those two questions. Most importantly, the metrics by which the CF community would feel that we as healthcare providers have done a sufficient job to equip you to make a decision for yourself.
So I'll speak to some of what goes into my thought processes when I decide to take risks, specifically involving contact with other people with CF. setting aside the clinic environment, which frankly I can't control, and frankly I acknowledge as the most dangerous place. And on some level it's kind of like, well, if I'm okay with clinic and the type of incidental contact that happens in clinic, I'm okay with that level of non-physical incidental contact outside of clinic, occasionally for good reason. So, for example, I'm not trying to defend intimate contact. That is nothing like happens crossing spaces through clinic. That's different. But to safely attend something like this conference or NACFC, I am all for wearing an identifying mark that I have CF to protect myself and others. I disagree with those in our community who feel it unfairly marks them as having CF. Like, no, that's about our mutual protection. I would afford you, and I would expect you to afford me, the same amount of respect that says, we may not know each other, but I have CF, we're certainly not shaking hands, and we probably shouldn't talk to each other. And just kind of glide on by and continue walking. That is something that is lacking from a rational policy right now.
Yes.
You could have a policy like CFRI does that says you will submit sputum culture within 2 weeks of attendance. You will identify yourself as a person with CF and make yourself known. And if you're growing certain things, I'm sorry, you cannot attend. And if you aren't, be aware that there are 8 other people who will be here that we can't promise exactly what they're growing, but this is what they were growing at the time. And they're out in California, CF Research Institute, whatever. I have in the past reached out and communicated to people I know will be in attendance at things like NACFC and asked, what y'all growing? I'm growing this. The last time I was treated for it, I used this. It is responsive. What are you growing? Do you mind telling me? What hotel are you staying in so that we're not pushing the same elevator buttons? You know, there are steps that could be taken to maximize individual protection that I take and that I try to take. And then it basically comes down to, is it worth it? Is it worth the small risk of contributing meaningfully to the CF community in this way, or building a personal friendship and relationship where I typically do not meet people indoors, but I have met people in my locale out for coffee outside. Because I care about them as people, because we've shared what we're growing, we're not actively sick, we're not coughing, we're not currently on IVs. Okay, we can talk about whether or not we both feel like, is it worth the meet for coffee? Sometimes that answer is yes, sometimes it's no.
And I would like to acknowledge that there are, this is going to be an individual choice. There are going to be people out there who, and I'm aware of some who don't feel that the risk is, they don't want to be, they have no interest actually.
But they get to say no.
And they get to say no. I agree with that. And if there are people out in the community who would like to contribute as well, we'd be happy to hear from them. We have another question here.
Yeah, it's Leona Pinsky from Vancouver. So I just want to publicly acknowledge Chris, because my daughter, who's 20 years ago, my husband and I were trying to enforce in clinic the infection control guidelines that didn't exist then, because we were a little bit ahead of the curve on our concern. And as my daughter's become an adult, and as I've spoken to Chris online, he's really made me rethink, not what I did when she was a child, because I really wanted to get her to adulthood in the best way I could, but he's really caused me to think about paternalism for adults with CF, because I know how much I hate it when I feel I'm being patronized, and just letting them make their own choices. And I really like what you said about CF Research Institute and getting sputum samples, and a condition of attending is disclosure and that sort of thing. I think there's a lot of room for us to think about these issues. On the other hand, then I hear about 3 young people in Ontario a few years ago, 3 young women that were hanging out a lot and all died within 6 weeks of each other in their early 20s. So as a mother, that makes me crazy. So it's a difficult decision, but I really want to thank you for, over the last couple of years, really making me rethink infection control in my adult daughter.
Well, you're welcome. And I think that if you think about our relationship, it's not about infection control, it's about risk-taking. Because it's not just infection control. I would suspect, have had numerous patients choose to become pregnant, that you wish perhaps they had not made that choice. and paid terrible prices, right? We assess risk on a number of fronts. I'm parenting a 2-year-old right now who's been in daycare since he was 3 months old. Last year was rough. I wouldn't trade that for anything. Anything. It represents all I've ever worked for as a person with CF. You know, it has driven my adherence to care before I even knew that's why I was adhering to care. And to take those things away or to not realize their value is, I think, somewhat misguided, though well-intended.
I think as an organization, as I mentioned, the policy impacts us frequently, constantly. One of some of the most common questions that we get are, when we have public events, can we have a bouncy castle there, right? These are those sort of inflatable jungle gyms, and all of the non-CF kids could participate, but you've got children sliding down and potentially sharing germs. You really wouldn't be able to recommend that children with cystic fibrosis also share those things. Things like face painting. Can you have that at an event? Or the princess balls that are frequently had, and sometimes where individuals' parents are participating in the organization and understandably would like to be able to participate. The ability to police is challenging because we do need to rely, it's an invisible disease, and we do need to rely on individuals being willing to disclose that they are living with cystic fibrosis. And I think to your point, Chris, and to you, Brenda, as well, education and destigmatizing it would be extremely valuable. I haven't seen any questions come in online, and I did have a question for you, Liz, and I've forgotten it. So
It'll come back.
hopefully it'll come back. We only have a few more minutes. I have one more question here over at the microphone.
Okay, I'm Kelly Grover, and I'm the CEO of CF Canada. And I think, John, what you're alluding to is really key for us as an organization. In my short time there, I have seen this is like the number one thing we wrestle with is how to implement a policy such as this. I'm busy making notes there because when I came into the organization, I used to work in HIV/AIDS and reproductive health, and it reminded me back in the time of HIV/AIDS, and I'm not comparing the two, but just the paternalistic sense that the community felt of what was being imposed on them from a public health standpoint. And I've wrestled with this as the CEO because this is a huge risk for the organization if something bad happens. And what I think Hugh was trying to get at, and I'm not sure we did, is informed consent. And how would we know we have informed consent? You are a lawyer, or an attorney, I should say, for the US, and you really are able to balance and conceptualize what is informed consent for you. And this is going to be our challenge of how to ensure we've got informed consent, and considering that the community is so divided. So I'm not even sure if we're wrestling with the policy per se or the importance of, perhaps we are, but for us as an organization, I can tell you the implementation of it is something that I know John and I have on our priority list to look at with the board, because it is causing almost more challenges at times in terms of dividing the community and being able to engage with the community who we're here to serve. So it's not a question as much of a comment about informed consent is, as you know, for the work you do, it is a challenging topic that people have wrestled with probably more than patient engagement. However, I would say it's very I have a strong, I lean towards engaging the community more and hoping to get to overcome the challenge of informed consent being a barrier, because I think that outweighs almost at times what I do think we're losing more than we're gaining at times.
Well, and certainly there's a difference between policy driven by science and risk and what we know versus potential legal liability. Those are two different questions. And if you want an ironclad policy around potential for legal liability, maintain a policy the way it is, realize you may have some people who may ignore it that actually don't increase safety at all, and live with it. But if you're interested in valuing patient voice, valuing patient participation in a way that is safe and respectful with consent, then have a very good risk waiver. Have a very good conversation about what it is to attend your events. And that's achievable. I mean, and frankly, from a legal perspective, the waiver I signed today to be here and participate was adequate. Because you do it. You already do it. You already say there may be people here. There may be people here with CF, even though, you know, we hope you're the only one.
And
but you still have that risk, though. You still acknowledge it.
And we have a question from our online audience.
Yes. Moriah Noonan would like to know, I am a 56-year-old CF patient. I have a question about gardening. I am quite aware of the possibility of bacteria in the soil, but I still do enjoy gardening. What is your opinion on this?
This is great. It goes directly to the question we were talking about, education. Val, do you want to address that one?
Yeah, sure. I've gotten this question before. So gardening specifically, you'd be worried about fungal elements that are within the soil, and we know you can get non-tuberculous mycobacteria as well from the soil. What I generally tell patients is if there's not a lot of aerosolization of the soil in particular, then it is probably less of a risk. Mulching and shoveling lots of and aerosolizing it is probably not a good idea, but if you're working in soil within gardens, then it's probably less of a risk. Again, I can't quantify it. And I can't say there's no risk. There are certain physicians who would recommend patients wear N95 masks to garden. Having worn those every week in TB clinic, it's not comfortable. I don't imagine that would be a very enjoyable experience. But if you're not aerosolizing it, you're probably decreasing the risk, and that's about as much as I can say.
Can I speak to that as well? I am an avid gardener. I am cystic fibrosis. I'm 54 years old. I'm 16 years post-transplant in July of this year. I choose to wear an N95 mask when I garden because there's also an organism where I live in the Lake of the Woods area called blastomycosis, which is dangerous to a lot of people, animals, let alone somebody with CF. I wear gloves when I garden. So I think this is where the risk reward comes in that we talk about. I know this is a risky activity for me, but I choose to take precautions and I gain my reward. And I think that's encompasses everything that we're talking about here right away. We need to have the information. We need to be able to make those informed choices. We need to know, like Chris said, hey, what are you growing? You know, are you sick? You know, we need to be able to make those choices of whether we want to be together. I'm not encouraging people to ride in cars together. I'm not encouraging to have to go back to the way things were when we had all these CF people congregate, because we know from past experience that's not a good way to do things. And I think what Chris and I are trying to get at is we want to rethink things. We just want to say, okay, we went from this end of the spectrum to this end of the spectrum, and I think there's room for improvement, and there can be something in the middle that might work for everybody. And we need to have that dialogue, and we need to bring that out. And where I said again, too, the Adult Cystic Fibrosis Advisory Committee would be really happy to work with people on this, because we're, you know, the voices of some of the adult community, and I think it would be very important for us to be involved in this in some way.
Thank you, Brenda. I'm going to ask, we have a couple of questions for a poll, and I'm wondering if we could pull them up. And I know that our online audience are a few seconds behind. You should all have responders on the table in front of you. And as we pull up that poll, I'm going to give a perspective of sort of a parallel, if you will, between an organization, an institution like Cystic Fibrosis Canada, and an individual. And so the first question really is just a question about demographics and who you are, and we'll get to that in a moment. But as an individual, I don't live with cystic fibrosis, but I've known people who live with cystic fibrosis, and those people are dear to me. And in my personal life, it's a choice that I've made that I don't bring them together in a social event in my home. And it's not because I don't think that they're losing something. It's just that in the absence of evidence isn't an evidence of absence. So I don't necessarily understand what that risk is, but it's, like I said earlier, it's an anathemic to me to the idea that maybe I'm putting people at risk. And this is a hypothetical person, if you will. But if I made that choice, and I have 3 friends, and 2 of them have cystic fibrosis, and they're happy to get together on an outside environment, and one of them isn't, and in my own party, in what I invite, and I say, yes, I'd like one of those individuals to come, I would expect the others to respect that decision. On the other hand, I would also expect of myself to be willing to discuss with them and to hear how that affects them. And I think by encouraging the conversation, we are in a position perhaps to encourage our audience, our community, the people we care about, to also respect that decision as an organization. So for the poll, are you an individual living with cystic fibrosis, a caregiver, a health professional, or none of the above? Those of you online, you should have a link at the bottom of the page. And we are going to have to wait for a few seconds before we get the answers, and we'll have a moment to see how that works. And for the second question, just is, if we can move to that one. Ooh, there you go. Talk about risk taking. Vacation. I actually I'm one of those individuals who's probably every time I see one of those insurance forms, I motorcycle, I bike, I scuba dive. If I could, I'd probably go hang gliding. My daughter did all of those activities as well. Not the scuba diving. She went hang gliding and rode a motorcycle. Liz, anything that you'd like to sort of, while we're waiting for the question, that you'd like to sort of summarize your thoughts on the whole conversation?
I think it's great that there's a conversation happening. I don't think anybody who looks after people with CF or is involved with people with CF wants people to feel that they're excluded or their voice isn't important. I think that there is a sense of risk that healthcare professionals that look after people with CF do bear and feel a responsibility. And I, from what you're saying, I believe that CF Canada also feels a responsibility to the people that they care about. I think that perception of risk is very individual. So the risk I'm willing to take for myself is very different than the risk that I'm willing to take for my daughter. And that is just an aspect of being a parent. And I think parents' voices are important. So it's important that, some people may feel included with a change and some people may feel excluded because their idea of acceptable risk is different. And, that's not right or wrong. That is just the perspective you come from. And the one thing is that when I do have a patient that decides to get pregnant, I recognize it's their decision, and my job is to inform them of what the risks are. And I have an opportunity to have a one-on-one conversation. What they decide to do with that information is their right, completely their right, and because it affects them and their family. Where infection control is different is that the risk is affecting other people other than just the individual. And so that just sort of changes the impact of the conversation. And the thing that I feel about the infection control risk is it's a much bigger audience. So unlike my patient who's pregnant, where I can sit down and I know I've got half an hour and we can have a conversation, I don't feel like I can do that due diligence to my 550 patients in the same way and have individual opportunity for questions and everything. And so it's all of those challenges. Not to say, again, that's what we have to deal with when thinking about this.
Thank you. Can we pull up the next question? We've got obviously an abundance of healthcare professionals, and I don't know what we have online. Hopefully we have an audience online who are also voting. this is really, it's a question about, do we continue the conversation? Is the infection prevention control policy a good, poor, or I don't know, topic for patient engagement and discussion? Is this, really what I'm trying to ask is, do we continue this conversation? That would be a good conversation. If it's a poor conversation, we can shut it down, I guess. And sometimes people don't know. What I'm going to do, we're going to end there. I want to thank our panel enormously for, as I mentioned before, it can be a contentious and an emotional topic. And I want to thank everybody for coming here and being willing to sit down and having this conversation. Thank you all, Brenda, Liz, Val, Chris. And as we close and we wait for the results from this, I have a number of people to thank. I want to thank all of the individuals who came and who attended the conference. I want to thank all of the speakers. They were wonderful. We've had just a really phenomenal day and a half, and I greatly appreciate it. I also want to send a shout out to our audio-visual people who have been absolutely wonderful in terms of quick changing the stage and ensuring that the conference moved smoothly. And I want to send a big thank you to my team at Cystic Fibrosis Canada. This would not have happened without just a phenomenal effort on the part of the team at Cystic Fibrosis Canada. What I am going to do in an effort, because frankly, my sanity was at risk, and there are two individuals that I would like to call up to the stage. If Sandra Pandatharatney and Nancy, I wish they had easier names. Smith would have been easier, you know. Strakowska would be willing to come up front here, please. And you know, because I want to give you a personal thank you. Really, this could not have happened without the two of you. And Sandra, I know you like chocolate, and I know the two of you like flowers. So thank you to the two of you. This really would not have happened without them. And for the two of you. And you can think of bringing them to our next staff meeting. I have to. We have a team meeting every other week, and the top item on the agenda list every week is chocolate. So, have the results come in? Momentarily. Yeah. I also want to give a shout out to Lisa at ThinkLink. I think everybody here has appreciated the drawings that we've had. I know that we had these a couple of years ago. And also, I guess finally, I believe, and I'm looking to my team over there, are we going to be, I believe that the live streaming is going to be available afterwards. We'll let our audience know through social media that the live streaming or certainly a video of it will be available, as well as we'll be looking to post the presentations of those presenters who are willing to have their presentations available. And so on a final, the poll, well, kind of overwhelming response here. I think we can, am I reading that right? Well, there's an I don't know, a small I don't know, there's a 0, and it looks like there's an overwhelming desire to continue the conversation. So kudos to everybody here up on stage. Thank you very much. I appreciate it. And I hope everyone enjoyed themselves at the Broken Arrow Conference, and I hope you all have a great end of day. For those of you, thank you to our sponsors. We couldn't do it. And for those of you who are going to the gala this evening, I hope you have a wonderful time. And thank you all very much.